Welcome back to Open Med School. Today I am going to discuss is classification and mechanism of action of antipsychotics. The psychiatric illnesses are basically divided into psychosis and neurosis. The major psychosis, schizophrenia, then comes the depressive illnesses, mania, depression, and mania and depression together bipolar. And the psychotic disorders are the long term theory is that it is due to dopamine driven pathology, but multiple neurotransmitters are also involved, including dopamine and serotonin. The simplistic view is that increased dopamine or serotonin results in psychosis, whereas decreased dopamine and serotonin or dopamine or serotonin results in depression. So, according to DSM-5, we can divide the symptoms as positive symptoms and negative symptoms. The positive symptoms are delusions, hallucinations, and disorganized speech. All these comes under the positive phenomena. Negative phenomena are flattened affect, reduced speech, and lack of initiativeness. These are negative symptoms. And the antipsychotic drugs are useful for this positive phenomena mainly, and some antipsychotics are effective for the negative phenomena. We will come to that. We divide the antipsychotics, previously known as neuroleptic drugs, into the typical or first generation or classic drugs, and second is the second generation or atypical antipsychotics. The first generation drugs again chemically divided into phenothiazines, thiazanthines, and butyrophenones. The phenothiazines are chlorpromazine, thyroidazine, and fluphenazine. Thiazanthine example is the thiotixin. The butyrophenones, the commonly used haloperidol. Atypical antipsychotics are having heterocyclic structure. The typical ones are, or usually used ones are the clozapine, olanzapine, quetiapine, risperidone. And this is a little more detailed classification dividing into the typical antipsychotics, the phenothiazines, the thiazanthines, butyrophenones, and miscellaneous drugs. And the typical antipsychotics, here you can see the clozapine, olanzapine, quetiapine, risperidone, and aripiprazole. These are the commonly used drugs. So just remember, divide into typical antipsychotics, atypical antipsychotics. Typical are the first generation, atypical are the second generation. And now we go into the mechanism of action. What is common in the mechanism of action? They reduce the dopaminergic neurotransmission. So the basic mechanism is blocking the dopamine. We know that the dopamine receptors are mainly the D1 type and D2 type. They are G coupled. D1 type are the D1 and D5 receptors, and D2 type are the D2, D3, and D4. And the antipsychotics block the dopamine. So there are mainly four major pathways for dopamine, and two are very important for the features of psychosis. They are the mesocortical pathway, mesolimbic pathway, which you can hear, and the nigrostriatal pathway, which is concerned with extrapyramidal problems, and the tubero-infundibular pathway concerned with the pituitary secretion, especially prolactin. So remember these pathways, it is here the antipsychotics act. So we'll take the little more detail look into which are concerned with the psychosis. This is the mesolimbic pathway going from the midbrain to the limbic system, and excess activity leads on to the positive phenomena of schizophrenia like hallucinations and delusions. If we block this, the positive phenomena can be blocked. This is what the typical antipsychotics do. Then comes the mesocortical pathway. So mesocortical pathway, when it is diminished, it leads on to negative symptoms. Example, lack of or restriction of emotions, thought, speech, and pleasure and attention. So basically the mesolimbic overactivity leads on the positive phenomena, and mesocortical pathway diminished activity leads on to negative phenomena. So again we divide you can see here the typical, they block the dopamine receptor D2 blocker. So this is the typical, and the atypical one is a combination. It has got a serotonin-dopamine antagonist action. To it act on the D2, it blocks it, and also 5-hydroxytryptamine to A receptor mainly. So atypical has got action on D2 plus serotonin receptors. And comparing the typical and atypical, the atypical has got low affinity to D2 receptors and very high affinity for the serotonin receptors. So this is a fundamental difference between the typical antipsychotics and atypical antipsychotics. So the binding of D2 receptor by typical one is tight. The binding of D2 receptor of atypical one is loose. So the importance is the atypical dissociate rapidly from the D2 receptors. So atypical dissociate rapidly, and so that the dopamine can come and act. So I hope you understood the difference between typical antipsychotic and atypical antipsychotics. And again remember, these antipsychotics act on other receptors. It can act on the alpha receptor, it has an alpha blocking action, it can act on the histamine receptor, it can act on the muscarinic receptors, and so the activities and adverse actions of antipsychotics differs depending upon how these block the other receptors. So now we have mentioned about the typical and atypical antipsychotics, and the typical antipsychotics are mainly useful for the positive phenomena, whereas the atypical antipsychotics are effective for the negative phenomena. What is the reason? The atypical antipsychotics block the 5-hydroxytryptamine receptors in the mesocortical and the nigrostriatal pathway, which we have mentioned. Blockage of the serotonin receptors by atypical drugs increase the release of dopamine in this pathway. That is, serotonin blocks the release of dopamine. So serotonin receptor blockage will lead on to release of dopamine. So in the mesocortical pathway, the presence of dopamine, release of dopamine, alleviate the negative symptoms. The same way in the nigrostriatal pathway, this release of dopamine counteracts the extrapyramidal side effects produced by D2 blockage. That is why atypical antipsychotics are less prone to form extrapyramidal action or extrapyramidal side effects. I hope this point is so very important to remember. Atypical antipsychotics blocks the D2 receptor. It has got a loose blockage. It usually easily dissociates. At the same time, it facilitates release of dopamine in the mesocortical and nigrostriatal pathway. So it will alleviate the symptoms of extrapyramidal side effects. At the same time, the negative symptoms, because negative symptoms are due to lack of dopamine in the mesocortical pathway. Hope this is clear to you. So other actions are there. One is the antiemetic action. This is due to blockage of D2 in the chemoreceptor trigger zone in the medulla. Second generations are less effective. It has got anticholinergic effects. So these anticholinergic effects are useful for counteracting the extrapyramidal effects, and it is useful for intractable hiccups also. So this is the, you can see the way the mechanism of the antiemetic action. In the area postremia in the medulla is the chemoreceptor trigger zone. So release of dopamine acting on the emetic center invokes vomiting. So blockage of dopamine will lead on to antiemetic action. Then other mechanisms of the vomiting, the vestibular system, histamine is released, acetylcholine, and the gastrointestinal tract, the serotonin is released, that also act on the emetic center. So drugs with antihistamic action, anti-acetylcholine action, or the anti-muscarinic action or anti-serotonin action can also lead on to reduction in the vomiting. So the adverse effects of the antipsychotics will be discussed in detail in the next session, and individual drugs will be discussed. And we should be careful regarding the neurological side effects. the neuroleptic malignant syndrome, behavioral problems like impulse control disorders, tardive dyskinesias, release of prolactin leading on to sexual dysfunction, and actions on the bone mineral density, orthostatic hypotension, sudden cardiac death and QT prolongation, myocarditis, metabolic effects, especially weight gain, neutropenia, and agranulocytosis with clozapine, and anticholinergic effects leading on to dryness of mouth, urinary retention. This will be discussed in next session. Hope it was useful to you. Thank you.